Oh yeah, there's 2 people that didn't do the extra credit quiz.
Yeah, so
Yeah.
I hadn't checked it. So I was very thankful for Group B that day.
Yeah.
So I was like, ooh.
I mean, I had it open for 12 hours, so if you didn't take it like that morning, you could at least take it like that evening. So.
I did, yeah.
Who? Oh. She's on here. Let's give everybody a few minutes that wants to join. I was about to say, Mia's not in this class. I have learned most people's names.
Yes, I just think some of it is hilarious and scary to do those times. Some of them do come out kind of. Anybody else say that they're coming for that? And Aaron said she wants to go.
I know Jessie's gonna come back up here at some point. She's dropping off her son this morning. Did you just take a picture of something? Oh, okay. I'm glad that like the hand all the way through the elbow. It's like you can't see my face at all, thank God. Rewatching these videos, I'm like, ugh, Jesus, Zoom does not make you look cute at all. Because I didn't know who anybody was. No, I just didn't know who anybody was. Yeah, there was a few people that, like, there's probably like 10 people that didn't. You would just probably see my cats, like, walking around, like, meowing or something.
You can have all the students put their email in there and just email us all. Okay.
Okay, we'll go ahead and head into lab, and then whoever joins. You did a pretty good job for missing. Oh. Oh yeah. That's why I was like, oh no, she didn't catch it on the second one either. Yeah. That's why I was like, I almost was like, you do know your position in your chest, right? But I couldn't tell you, so yeah. I was like, maybe she'll figure it out. And then your long button is your leg this way. I'm just like sitting here like the whole time, like, oh my god, something's gonna happen, it's gonna break. This is already bad enough that we have to deal with this nonsense. Who wants to be my model today? Okay. Go ahead and put your back against the board. And if somebody can like swing that this way so that you can find the whole thing. There you go. There's me. Anybody notice at their clinical sites yesterday that you didn't have cassettes? They have a room that didn't have a cassette in it. Oh yeah, like the grids. Yeah, taken out. Yeah, because a lot of those rooms are like Bluetooth now.
Oh my gosh, really?
Yeah.
You moved to the
They have one of those that I'm selling and I hate it so much. It's so much faster.
Showing everything.
But then also I feel like I'm not really learning.
Low too high.
Yeah.
Kind of doing it for you.
Yeah, exactly. That's why
So I even asked her, like, if I'm getting comped, can I only get comped on like not just
Yeah.
Even though it's helpful. I
Yeah.
can learn it, but I want to actually learn.
Yeah. All right. So we're gonna do humerus first. So go ahead and slide over. We're gonna do her left arm.
Yeah, let's try that.
Do you mind holding it or?
I don't mind.
Okay.
This is cool. I can like watch and learn.
Watch and be
That's-
nice.
We'll put it.
So humeruses are just a little bit tricky because you want to make sure that you get all the way to the top of the shoulder. You want a little bit of light above your shoulder when you're collimating. So notice how I pushed her as far over as I possibly could. You want just a little bit of overlap on like a little bit of their anatomy, but you're going to elevate their arm away from the side. So you probably could even slide over just a little bit more. We're going to get there because you don't want to cut off the shoulder joint right here. So you want about a third into the clavicle, and then make sure you have her shoulder joint, which is right here. Turn her palm forward. Don't rotate your body. And then just bring your arm as close to the IR as possible. So you want everything to be straight. This is your AP humerus, so you want just a little bit of collimation. I've already opened it to 17. If you feel like you're going to cut off the top, you could always bring it up after you position it to make sure that you have just the elbow joint. So always feel where your elbow joint is at and make sure you have just a little bit of collimation above her shoulder joints. That way, if you have, this is your shadow, you want to make sure that you have the soft tissue in there too. You don't want to cut out your soft tissue. And then you just center, I actually end up centering it perfect. So make sure you collimate down so you want the light just about, or just past the arm to make sure you don't cut off any anatomy down here because you're elevated away from your body. So So that's your AP humerus, 40 inches, again, like mid shaft of your humerus. The only difference from AP to lateral is bend your elbow for me. Is all you have to do is do that, literally. Make sure that the collimation is open left to right, and you could open it a little bit more just to ensure that that's in there. So she's in a true lateral going this way, and then this has also caused her to rotate her greater tubercle forward. So the book shows you can bring your arm down to the side and then internally rotate, but a lot of people don't like to do that because it hurts their shoulder. So the cross is totally fine too. So you can either do it this way, or you can internally rotate as far as you can with your hand so that everything is rotated into a lateral position. Whatever's easier for your patient. If you're doing a humerus x-ray, likely it's because they're trying to rule out a humerus fracture and they're not going to be able to do that. So, and then just make sure everything is lined up. You can do these flat too, same positioning. The only difference is that they're flat instead of standing. All right. So your shoulder, step back over to your left. And then you're just going to change. I always like to adjust my collimation first to make sure that I'm in the correct field. I also practiced on film for a little while. So you got used to the different size cassettes because that's the company that I worked for. We had 8x10 all the way through 14x17. So your first position, you want to make sure that you have all the way over to your clavicle. So your clavicle is going to end right there at your jugular notch, which is just that like little divot right here. So you want to make sure your collimation either goes just past that or like right into the jugular notch. You want to rotate your palm out for your external. So this is your normal protocol. So you have an external. The only difference for the internal is you rotate your hand back. So if you're positioning, just be like rotate your palm out, forward, rotate your palm back, internal, and then we'll jump into the scapular Y in just 1 second. Make sure your collimation is just above the shoulder and then just past her scapula. Her scapula is going to end about right in here. So you want to make sure that you have all of it. If for some reason on your external, say you didn't open the collimation left to right big enough or top to bottom big enough, you like clipped off a little bit of the scapula or a little bit of the clavicle internally or inferiorly, then you can on the next picture when you do your internal rotation, you just open up a little bit bigger. You don't have to repeat the whole series because the only difference in the shoulder external internal is the rotation of your humerus. That's it. So never repeat your external just because you clipped anatomy because you're going to do it on the internal anyway. It's the exact same picture. The only thing that's different is rotating that shoulder. That's the one time that if you clip anatomy, it's okay because you're going to cover it in the next picture anyway. So for an AP scapula, go ahead and put this hand on your right shoulder. So I kind of gotten accustomed to doing AP scapulas now because that's kind of like South's like way of doing life is they like AP. So you put your hand on the back of their scapula and rotate them. So she's in an RPO position essentially. A good way to check to see if they're in the correct positioning is if you were to take your hand on the back of their scapula, which should be flat, and rotate your hand to the IR, it should make a straight line straight in front of you. You're almost going to be in a true Y position, and then you would just collimate to the affected shoulder. You can even slide her over, go to your right a little bit. So as she stays the way she is, and then you can collimate a little bit tighter from left to right. Because you really don't need anything other than just that Y that's being created back here with your scapula, okay? And then turn around, so you're facing the board, you can put your arm down. So if we were to do that same shoulder this way, it'd be the same concept. Step over to your right a little bit. Keep going. So you want to rotate her the same way. You can also do the same technique. You can put your thumb on the back of the inside of their scapula. Move over to your right a little bit more. Leave their arm down by their side, and it would be the same kind of rotation. You keep rotating until your hand is straight, going into their shoulder. And then again, you can just adjust your collimation left to right just a little bit. So if your collimation is about their spine right here, open left to right, and you have the scapular border right in the middle on your CR, then that's the perfect amount of collimation. You don't want it to be way open, left or right, this way. or top to bottom. We don't need to see all the way down here or way up there by her head. So you want just enough to cover your actual scapula. Okay, so everything is at 40 inches. Notice when I did the shoulder and humerus, once this CR was in place, you don't have to move this again. You don't need to be going up and down constantly, okay? You should already be lined up. The only thing that you're doing is adjusting your collimators, and that's it. All right? All right, relax. Go ahead and turn your back against the board. So clavicle. Go ahead and step over to your right. Come back some. So we want about 1 inch above. Her clavicle is right here. So you want your collimation open about 1 inch above, 1 inch below. And then this one, just line up your CR again with your feet. And then you'll open a little bit left to right. Jugular notch just outside of her shoulder, that's your AP. The only thing that you're different that you're going to do for your axial is rotate it to a 15-degree angle. So 105. And back up to the exact same positioning. Here you might have to adjust this a little bit just because you have an angle now. But that's the only difference. You shouldn't have to change it too much. And again, this is just to flatten out your clavicle. Make sure if you have a fracture there or if it's dislocated, everything realigns itself. So clavicle is super easy. You don't have to do anything with your arm. Everything's neutral position. Okay. Your scapula, which you'll probably never really see over it. So put the back of your hand against your forehead. So this is going to flatten your scapula to the IR. We're going to find about central, so move her over just a hair, maybe about right there. You can collimate, you can bring her back over just a teeny bit if you want. The point is not to cut off any anatomy, so you can be a little bit more open if you feel a little bit safer that way. Top to bottom, just a little bit above her shoulder and a little bit below where the scapula would lie. And then just keep an eye on your patient that they're not swaying on you before you take the exposure. So that's your AP scapula. Relax. And then you do the same thing for the scapular Y that we already went over. So you bring this hand over to your right shoulder, rotate them. This is actually the easiest way to do it now, I think, because I've gotten so accustomed to doing it for me. And then you just eventually you can just start eyeballing it to put them in the correct position. You don't really have to feel on them anymore. But always get in the habit of touching the back of their scapula, because if they're straight perpendicular like this, you're likely to get a perfect Y. If the patient has a dislocation and you saw it in the AP external or internal shoulder views or humerus, and you see that they have an obvious dislocation, they're not going to be able to bring their hand up like this. So in which case you either shoot at PA or drop your hand down. You can keep her in the same positioning, but you just keep their arm down by their side. And you just rotate their body, that's it. But just bringing their arm up like this kind of helps with your positioning to get your scapula so you can feel it, okay? And then I can't really demonstrate AC joints if I don't have any weights for her to hold, which that won't be under practical anyway. But you would just open bilaterally across her clavicles. Come back to the center. And then you'd be at 17.
And it would just be like all this. It would just be all this up here.
Yeah.
Like
So you would just collimate it down. And that's it. The only difference would be is if she had weights in her hand versus no weights in her hands. That's it. That's it for AC.
And that's just like dropping.
Yeah, just to pull these open.
What
They're like pounds, 10 pounds or something. Yeah.
What if you have someone who can't
There's a positioning in the book that if they can't, you would
hold like 10 pounds, you know?
Yeah, well, usually the hospitals only have like a certain weighted sandbag. So you put them on the table, and then your table, you use the floor table where they're going backwards and holding onto a sheet. So it kind of does the same thing. They're elderly. The likelihood of them having an elderly patient do it is unlikely. So, but yeah, that's it. Good. Questions? No.
Maybe we should practice.
All right, y'all start practicing. make sure no one has questions at home. You guys can split up too. You guys can use the other room if you want. Yeah, Jen, that's pretty common. Ethan said the same thing. If you see that your techs are not shielding in clinical, I don't care what they're doing. They're paid. You guys are not paid. So if you're comping, they will mark you wrong and say you don't get your comp because you didn't shield that patient. I don't care if they're 80. You shield all your patients, okay? Yes, for these positions that we just went over, it'd all be waist shielding. Anything up to the elbow, you can do a full torso shield. So. All right, guys, I'm going to close out the chat and stuff. And just email me if you have questions, or you guys can come up to the school. I'm here till 1, okay? Okay, bye.